Welcome to Focus on Health, a series of educational programs highlighting current health issues sponsored by the School of Nursing at Salisbury University. I'm Dr. Mary DiBartolo, Professor of Nursing at Salisbury University and host of the program. I welcome Dr. Catherine Smoot. You're an ophthalmologist here in Salisbury with the Chesapeake Eye Center, and Dr. Bob Massof. You are a professor of ophthalmology and neuroscience at the Johns Hopkins Medical School. And today we're here to talk about the topic of low vision and some of the resources that might be available to our members of our community through the Lions Club. But I believe we first want to talk about what exactly does low vision mean, and then what are some of the causes of it. So I'll let you two medical experts review that for us.
Well, thank you, Mary. And one of the things I always talk to my patients about is think of the eye like a camera. And every part of that camera counts, from the lens all the way down to the film of the camera, all the way to the picture you see when you're looking with your brain. And our visual pathway is very similar. We have an eye that has a lens that brings the focus. Then we have the film, which is like the retina. And then we hooked it to that great computer with a cable, which is our optic nerve. And that computer is our brain and the visual cortex. So if you always kind of think of that camera hooked to the computer, it'll help understand our conversation better. There are a lot of diseases that can affect any part of the eye. When we hear a lot of the big diseases we've talked about in the past on your show, a lot of times it will involve the retina. And a good portion of low vision is because of damage to the retina. Now, that's not the only cause, but it's a good portion of it. And one of the key players in damage to the retina is macular degeneration. What does that mean? If you think of that retina, that film of the camera, like a dartboard, the whole thing counts for points. But in a dartboard, the bullseye in that center ring means the most. That's where you really score the game. The same thing with your retina. Your whole retina counts, but that macular area, a very small percentage of that retina, is your central vision. And as Dr. Massof has pointed out before in our conversations, that's like what percentage in the brain?
Well, it's less than 1% of the retina, but it's more than 50% of the visual part of the brain.
Yeah, that's really a huge representation. So if you have a disease like macular degeneration that has damaged that central macula, well, you're profoundly visually impaired. I think that we also have to think about diabetic retinopathy. People poorly controlled diabetics, or they have those changes in the blood vessels that leak into the macula, damage the macula, same problems. Macular holes, macular wrinkling. Now, that's not the only cause of visual impairment. We have to think of optic nerve damage. We have to think of conditions like stroke that affect your visual field, glaucoma, which is optic nerve. There's so many conditions that can lead to visual impairment. Now, understand, I haven't used the word blind. I hate the word blind. Blind has a bad connotation. Blind says you're done, to me. But when you sit there and say visually impaired, it means there are hope, there are tools, there are resources to help you. And I think that's what Dr. Massof and I are here to talk about today, because one of the challenges I have in my office on day-to-day is to give people hope, to let them understand that there are things they can do.
Well, the diseases you described are common in older people. And so if we do a head count of how much low vision there is in the country, we find that more than 70% of people who would be classified as having low vision are over the age of 65. Okay, and they're largely caused by these age-related eye diseases that you mentioned. These diseases have been major advances over the last several decades in ophthalmology to treat these diseases, but they can't be cured. We can't get rid of them. And because we're talking about nerves in the retina, nerves in the brain, that once they're damaged by the disease, in most cases the damage can't be reversed. So vision loss that occurs often is permanent. Whatever part of the vision may be lost. And that can form blind spots, it can form blurry vision. There are different manifestations of the visual impairments. All of these visual impairments that if it interferes with your ability to function in your normal way, we call it low vision. Okay, and low vision is to distinguish it, kind of like hard of hearing, as being distinguished from being deaf. Low vision often, at least in the minds of the public, is distinguished from blindness in that you have some vision that you can still use, but, and it's different in different people, how much vision you may have or how much information your vision is providing you, but it does cause problems. Okay, many of the programs that have been set up to help people who are visually impaired were originally set up to help people who were severely visually impaired or blind, totally blind, and not just legally blind. But those programs were set up in the 30s and the 40s and of the last century, and the demographics, how low vision is distributed in the population of visual impairments, have changed dramatically. And that's largely due to the fact that we live longer, and many people are living longer than their eyesight. And this is a problem that suddenly it's gone from being that the people we have to help are children or working age adults who maybe were born with severe visual impairment or born blind or acquired blindness as a result of disease that occurred very early in life or injury. And then to now a program that we're dealing with people who grew up with normal eyesight, who lived most of their lives with normal eyesight, have learned how to acquire information and function, and now suddenly they're visually impaired, and that can have a much more dramatic effect on them than someone who may have much more severe visual impairment but grows up with that impairment and learns how to live with it. So a big part of it is turning our attention to how we can help people live with the vision problems they have as a result of these primarily age-related eye diseases, and how they're going to how they'll be able to function and get their lives back. And so it's really rehabilitation as a service that is being provided to people with low vision, and sometimes ophthalmologists will provide those services themselves, but ophthalmologists are in short supply compared to the number of people who need ophthalmologists. So to train somebody for, what do you get, about 500 years of training
It feels that way.
to be an ophthalmologist, and then to suddenly say, well, we want you to also rehabilitate those patients. Well, you know, if you get surgery on a joint or have a muscular problem, you may be referred to a physical therapist to help recover that function after the treatment's done. And the same is true with low vision. Low vision rehabilitation is part of the team, and being able to refer people to get these low vision services is helping the living with it part of the visual impairment, whereas the ophthalmologist has to focus on the disease that's causing it and managing that disease.
And I think that's a really important part. So just to what you said, to your point, I have somebody I've been following for, the last 15 years, and then one day they come in, they've had sudden visual loss in one eye, and it's the macular degeneration or the diabetes or something has leaked into their macula. I can always see them being very discouraged, and the fear, the first question is, am I going to go blind? And my answer to that generally is, you're not going to go blind. I don't even like to use that word. This may impair your vision, but there are services and things that we can do that will help you maintain your activities of daily living in a functional manner. And that's an important conversation to have, and I hope that your audience understands that there are resources. You may not be jumping in your sports car and driving over the Bay Bridge, but there shouldn't be a reason why you couldn't live independently with certain tools, why you shouldn't be able to ambulate safely, know your family, these type of things. And so we'd like to erase some of the fear factor with this, I think, is an important thing.
And some of it is learning to know what to expect. That many people are depressed as a result of this. It's like any loss. You've lived your whole life with normal vision, and suddenly you're having problems with your vision. And depression rates are very, very high. I think second only to cancer in terms of in this population. And so a lot of what has to be dealt with is kind of the initial shock, dealing with the loss, and having somebody who can provide counseling, who can provide insight into what the problem is, what the actual impact of the problem is, and what can be done to live with it. That this is not something you have to go alone. This is not something you're expected to struggle with in between doctor appointments. That this is something that we have technology, we have ways of doing things that are called adaptations, way to change how you do things in order to function more effectively with the vision you have. So it is a team approach, and it's been around a long time, but not in abundance. And so.
And I think low vision, we're not just talking about your visual acuity going down. Dr. Massof and I were having this conversation a little bit earlier, that we don't think about somebody who may have, say, 20/20 visual acuity, but they've had a stroke, and they've lost part of their visual field. And you lose part of your visual field, it can be very challenging for your ambulation, maybe your reading, all these things that can be quite frustrated. That's another good indication, even though you have good visual acuity, for low vision resources. And the other question I would have for you is, when would you like me as an ophthalmologist to get my patients to seek your services?
I think that there's probably no hard and fast rule, because many of these things come on slowly, and people may complain about vision problems early that are more of a nuisance than really causing serious disability type problems. But I think when the patients start showing signs of anxiety, when they start showing signs of frustration with daily activities, if they verbalize these things, or family members are verbalizing it, that's certainly a sign that, low vision services are appropriate. As a rule of thumb, you can use certain criteria based on your visual field measurements or based on your visual acuity measurements and say, I think this, and for younger people, for very young people who get low vision, a lot of times they can accommodate for that vision loss or visual impairment. For example, they can bring things very close and focus on them. Okay, but that makes things bigger, easier to read. As you get older, if you're over 65, you got to be out here.
Younger than that. These are a testament to that.
My arms aren't long enough anymore.
Right.
And so when that happens, you have to have other tricks in order to do that same thing. So the impact of a 20/40 or 20/50 visual acuity, which doesn't sound bad, you can still drive with that without a restriction on your license, 20/40 certainly. It still can cause problems with everyday reading demands, being able to read your medication labels on your bottles, and it might not be everything, but here and there, and they're critical things that need to be addressed. And so there are tools that, and the intervention might be fairly quick. Just become aware of what you can use to do to overcome these little hurdles. And as they get more serious, or if the impairment's more serious and requires more extensive rehabilitation, then there are all kinds of programs that low vision specialists can direct you to get these more extensive services. But it's a kind of thing that I think it's important that patients be kept in mind from the point of view of what's the impact of this problem on their daily lives. Not just the ability to function, but also emotional impact and psychological
Quality of life,
impact.
it's all very important. I know, so when someone sees their eye doctor and has one of these problems, in some cases there are treatments that can keep it at bay, but it sounds like a key focus is how are you going to adapt to whatever low vision you have. And that's where the Lions Club will come into play in a few minutes. I know we have someone else waiting in the wings from the Lions Club who wants to talk about the programs that they have in place to help people with low vision problems.
Well, to your point, when I started the practice just a couple of years ago, we saw a lot of diabetic retinopathy. And I am not seeing that level of retinopathy now, and I think that's due to advances in education. I think it's due to advances in treatment, advances in diet. So that's a lot better. I mean, I'm not saying we don't have it. I'm just saying I'm not seeing nearly as much of the profound visual impact as I had. The macular degeneration. wet form of macular degeneration is about 10% of the case, but it's 90% of the visual impact. And with the advent of the new anti-VEGF drugs that are being used, the injections that many people are having, we're holding off a lot of the profound vision loss that we always saw with this. So now these individuals, through the technology and the advancements in medicine and the treatments, who would have seen you for profound visual loss, are now getting in with a moderate amount of visual impairment, so that some of these advanced techniques and tools that you all are offering have an even greater impact.
Right, and starting early is not a sign of weakness or a sign of giving up or anything of that sort. It's making life more livable. And so as soon as you're having problems because of your vision, that's the time to seek these services and get the help you need. That being said, there are other conditions like glaucoma, sometimes stroke, where you could have large amounts of visual field loss and people won't notice it. In fact, glaucoma is called sneak thief of sight because you can lose tremendous amounts of vision and you don't really notice it's gone. And you might be attributing the cut on your forehead to just inattentiveness when you walked into the open cabinet door, but actually it's a consequence of that. So in some cases, they may have to be educated that, you have lost a certain amount of your visual field because that's measured in the ophthalmologist's office, and then and you may not be aware of it, but this is having an effect on what you do every day and your safety. And so there are techniques that can be used to help people become aware of what they're not seeing. Just like we don't miss what we don't see behind us. Right. Okay, and as your visual field shrinks, you just tend not to miss it. That just becomes part of what's behind us.
And those patients are a little challenging from the ophthalmologist point of view because there's a lot of denial. And that plays back to what you're talking about, the emotional component. Right. When you sit there and tell someone who's seeing 20/25 that you have lost, 85% of your visual field for whatever the condition may be, they're like, no, I see fine, doc, I see fine. And it's really hard to have that conversation about you could benefit from these low vision resources because there's a lot of denial. So I would encourage your audience that if your ophthalmologist has had this conversation with them about you've lost visual field, you really are no longer legal to drive, or you have to be careful with your steps, or you have to be whatever, now's the time to have the conversation about the low vision services to help educate you in the way that Dr. Massof is saying, that they're techniques.
Well, before we bring in our next guest from the Lions Club to talk about those services and specifically, let's give you one last hurrah to remind our viewers of when and how often they should be seeing an eye doctor to hopefully prevent some of these problems, getting the pressure checks in the eye and so forth for glaucoma.
I would say as a overview, as you get older, get an annual eye exam. If you have a family history of glaucoma, follow the guidelines that your ophthalmologist presents with you. May need to be seen more frequently. If you're diabetic, you absolutely have to have an annual eye exam. If you have been diagnosed with macular changes or have a strong family history, certainly annual, unless your ophthalmologist finds specific findings that indicate a more frequent visit. And try to identify these things early. Early detection, early treatment, and early intervention when problems are found is the key to preserving vision. So.
Now, define older, though, for a person that doesn't have diabetes or a family history of certain things. Like, what are you saying that age is where people should definitely say, I need to see an eye doctor every year?
Well, older is a moving target for me, too. So I would say, when you start getting into your, certainly by 50, in your 40s, you're going to start noticing that near vision issue changing. Again, depending on your family history would be your guideline, and speak with your eye care professional about what clinical indications. But by 50, I'd say at least by 50, an annual eye exam.
And if you have a Medicare card, you're definitely in that group.
Right.
Well, thank you, Catherine, for sharing your knowledge of low vision and so forth.
Thank you for having me, Mary. It's been a pleasure to share your show with Dr. Massof today.
And we'll be back in just a moment. We're back, and now that we've talked about the medical side, we are now going to move on to the resources side, a very important piece. And joining me now is Paul Hawkins. You're the Executive Director of the Lions LOVRNET program. You're also a longtime member of the Lions, 30 plus years, past district governor and so forth, and you have the tie to show it.
That's right.
But we're going to talk first about what is the relationship between this LOVRNET group that is housed up at Hawkins and through the Wilmer Eye Clinic and so forth. And Bob, you're going to take care of that end for us. And then you're going to talk to us specifically about what the Lions Club has to offer our local residents in terms of low vision resources. So Bob, take it away.
Well, the Wilmer Eye Institute at Johns Hopkins, more than 30 years ago, partnered with the 6,000 Lions Club members in Maryland, Delaware, and District of Columbia to develop a low vision program at Johns Hopkins, which we talked about in the first segment. And that the Lions raised a considerable amount of money to support that program. And we've had a long time, more than 30-year partnership between Johns Hopkins and the Lions of this area to work on the problem of low vision. And it's reached a point now where we're talking about how do we get service out, not just in the center of Baltimore or in Washington, D.C., but out into the other areas of these states and their jurisdictions in order to reach the patients closer to their homes. And that's where this Low Vision Rehabilitation Network program, LOVRNET, comes in.
Lions' motto is "We serve," and our association with Wilmer and the Johns Hopkins University was basically, as Dr. Massof indicated, financial support. About 5 years ago, Dr. Massof talked to us and said, why don't we go a little bit beyond that and practice our motto? And that, I think, started out our concept of the Low Vision Rehabilitation Network. Lions actually got involved in service to these individuals with low vision. We set up the program with 4 what we call task forces. There was a community outreach task force, which was a group of Lions that went out and provided educational information to the public and also to eye care professionals on what can be done for individuals with low vision. We had a task force that's involved in patient interviews. One of the real problems with care for low vision individuals is that it's a very time-consuming process. A lot of time spent in gathering information on the patient's history, what their capabilities are, what their desires and needs are. And this opportunity came up for Lions to go out and perform a pre-appointment interview. This is done on the phone, and we've done hundreds of those already, thousands probably. There's also a direct services task force. This is where Lions actually got involved directly with the individuals. Mostly that involvement was in transportation to doctor's appointments, but there are also other opportunities where we actually got an opportunity to go into a patient's home and either do a survey or perform some function. And the last task force was the administrative task force, and these are the Lions that are involved in actual development of or work on the computer programs and the administration to make this whole thing work. Now, when I came onto the program about 4 years ago, I came on as an interviewer. I spent about a year doing that. The opportunity came up to lead the Direct Services Task Force. I accepted that position, and one of the things, again, our motto is "We Serve," and a lot of us Lions have a concept of what we call becoming a Lion. When you're installed as a Lion, you get a pin and everybody calls you a Lion. But at some point, individuals may actually become a Lion. And that's when you really understand that what you're doing and what you're involved with is something that's important and something that's helping other people. I had an opportunity as a direct services volunteer. A lady in Baltimore had a fire in her home. She had to move out of her home while they reconstructed it. She was a low vision patient. When they got done with the work on her home, she moved back in, and it was a beautiful job. She walked back in there, and she had beautiful white walls. She had nice white face plates on all of her light switches, and white face plates on her outlet covers. And she was really having difficulty turning on the lights or plugging in her appliances. We had a therapist out to her home, and a very simple fix was determined. And they called me and said, "Paul, can you go out and get 37 switch plates for outlet covers and 14 covers for light switches?" We did that. I went over, I installed those switch plates, covers, about 2 hours, and the look on this lady's face was just wonderful.
Sure, I guess they
And
weren't white, huh? They contrasted.
They were black.
Okay,
They were black.
very good.
And it's something that was another opportunity for me to become a Lion. So what we're doing now is we're looking for Lions, we're looking for volunteers, and we don't take just Lions. Anybody can volunteer by going onto our website, www.LOVRNET.org, and
We'll
volunteer.
post that information at the end of the program
Thank
as
you.
far as helping you with recruitment, but also if you could just give us some other examples of services you could specifically offer to residents in this area with low vision. We'll tell them where to call, but what kind of services can you provide? Or you're saying there's funding there to help with certain things?
A lot of clubs. We have Lions clubs throughout the area, and each club operates in their own community, and they provide services. If an individual has a low vision problem, they can contact LOVRNET, and we can address those problems. We can direct them to providers that might provide services, get them an evaluation, and get them into a rehabilitation program. If there's other individuals or other problems that an individual may have, the local Lions Club may be involved and help them out in that area.
So you are connected with the locals Lion Club here in
We're all
Salisbury
Lions.
area. Okay,
We're all
of
Lions.
course. I guess I know that MAC has the Bay Area Center for Independent Living, and they have all kinds of very helpful technological gadgets to help people with low vision. So do you do any work in that area where you can provide the funding or such for those kind of things? Or
Again, if someone has a requirement for a specific piece of equipment, that would normally go through an individual Lions Club. Now, LOVRNET itself does have an online store where we offer both regular supplies that individuals with low vision might use, or actually medically approved equipment that must be prescribed by a doctor. We have two websites, or two shopping carts, one for the public and one for the doctors,
okay.
that they can buy. I
I think that's important. Adaptive aids can be very helpful, and sometimes they're not within the price range of some people, or insurance doesn't cover it sometimes. So that's good could be an important resource
And again, that's where the local Lions clubs come in
terms of providing funding
And
for
serves
that. They can
assistance.
try it out at Mac or whatever. Sometimes it's hard to order things online if you can't try it out first. I'm from that generation. I like to try things on before I order,
Right.
but you know, it just sounds like you're doing a lot of really important work in that area. Anything else you'd like to add?
We're expanding all the time. We're looking at opportunities to assist assist low vision patients in New York. Where right now we have submitted a request for a grant from the Patient-Centered Outcome Research Center in Washington. It's going to take us into 28 different states if we get that grant, and it'll be involving Lions in all of those areas.
So, Paul, I imagine part of your education focus is to educate the local eye doctors to let them know what the Lions Club might have to offer through this LOVRNET program?
That's correct. Our community outreach volunteers actually have visited over 5,000 different providers in the Washington, D.C., Maryland, and Delaware areas. We would like to continue to do that and provide them with information on what we're doing and how they can be involved in that.
Okay, that's great. Now, Bob, just maybe summarize for us one last time what, you know, this LOVRNET, what the rehab network has to offer.
Well, we've often heard that it takes a village to do certain things. In healthcare, it often takes a network. And the network consists of volunteers like the Lions who are providing direct services as well as these other things in education. It requires the professionals who provide the healthcare services to these patients, provide as well as therapists who provide more direct services, sometimes in the patient's home, sometimes in rehab centers and so on. And coordinating all those services and bringing the patients in, the people who need the services, and matching them up with the people who can help them and to get the information to them that they need. That's the role of the network, and that's where the name it comes from.
Okay. And Paul, if a person with low vision, they can call LOVRNET directly. They don't need a doctor referral?
You can self-enroll.
Okay, that's good news. We just got to get people to, you know that it's there and have the gumption to do it. Because as Dr. Smoot mentioned earlier, that sometimes people are in denial or they have no idea they're losing their vision gradually. So that's very important to know. And what we'll do is we'll post a slide at the end of the program with the website, the email, the phone number that people can call LOVRNET if they have questions or are in need of low vision services.
We appreciate that.
And thanks to both of you for being on the program. It's certainly informative to learn more about these problems associated with low vision, but more importantly, the resources that people can tap to help with this.
Thank you for having us.
And thank you for giving us this opportunity to get the message out.
And thank you for joining us for this edition of Focus on Health here on PAC 14.